I'm Cindy Jackson, Chair of the Grandmothers Against Gun Violence Foundation and moderator of today's program. Gun violence prevention, stopping intimate partner deaths, and the new gun violence prevention federal focus. We have two presentations today, each offering information that will impact action in the field of gun violence prevention and in all of our communities. First, we'll hear from Dr. Julie Kafka, who's a new assistant professor at the University of Colorado School of Medicine. Dr. Kafka, who has just recently received her doctorate from the University of Washington, was a recipient of research funds from our foundation, and we supported her research. Her research that she'll share today, Risk Factors for Intimate Partner Homicide, a case-controlled study focused on male perpetrators of intimate partner violence and the role of firearms. Her work provides a better understanding of risk and contextual factors that can help explain why some men in abusive relationships may commit homicide and while others may not. There will be time for question and answer after Dr. Kafka's presentation, so please use the Q&A button to send your questions for Dr. Kafka. Dr. Kafka, it's on you.
Great, thank you so much for that introduction. I'm gonna share my screen. Let's see, can you see that okay? Great. Okay, so today, as Cindy mentioned, I'm gonna be sharing a little bit about my research on the role of intimate partner violence in gun-related deaths with a close look at the Grandmothers Against Gun Violence funded project that I did on preventing intimate partner murder-suicide. I want to acknowledge that these are difficult topics. If you're in distress or you're worried about someone you know, please do consider reaching out for help and, of course, take care of yourself during the program today. The original research that I'm sharing here actually builds on funding from several different bodies, including Grandmothers Against Gun Violence. I have to note that the findings and conclusions reported here belong to myself and my co-authors alone. They don't represent the views of our funders or our data providers. I'm also sharing some findings that have not yet been published. I'll have a clear note on any slide that contains unpublished work. Please do not share those findings online with the public or with the media at this time. I'll be sure to let you know when that research is finalized and ready to share. I'm going to start with an overview, providing some background on what is intimate partner violence, which is really my primary research area. And then I'll share a little bit about my dissertation work, which sought to really look closely at the role of intimate partner violence in gun deaths in the United States. Then I'll highlight preliminary findings from my Grandmothers Against Gun Violence project, looking at intimate partner murder-suicide. And I'll conclude by discussing some next steps for research and prevention. So intimate partner violence refers to any physical violence, sexual violence, psychological harm, or stalking by a current or former intimate partner. So that can be people in a dating relationship, a marital relationship, or it might be people who are divorced or separated. About 2 in 5 women in the US report having experienced intimate partner violence in a way that negatively impacted them at some point in time. That includes feeling fearful or concerned about their safety, needing help from law enforcement, requiring medical care related to an IPV injury, or missing 1 or more days of work or school. For men, the proportion is smaller, but still notable at about 1 in 4 men. Now, I want to note that when violence is severe, there's usually one person who is primarily perpetrating IPV and the other person who's primarily being victimized. So for this reason, you'll hear me use the terms perpetrator and victim survivor today to describe each party in the abusive relationship. This in some ways is an oversimplification, but in many cases it is appropriate. So how are guns used in IPV? Guns are highly lethal. So when an abusive individual has easy access to a gun, this can really elicit fear, intimidation, and ultimately compliance. Gun-related threats, like the example I have here on the slide, can really scare someone into staying in an abusive situation against their will. When an intimate partner uses gun threats this can really lead to adverse health consequences for the victim survivor above and beyond what we would expect to see from partner violence alone without gun threats. Guns, unfortunately, are also used to kill. We know that when women are murdered, in the US, 2/3 of the time they're killed by a current or former intimate partner. And when a man who is perpetrating IPV has access to a gun, they're 5 times more likely to kill their intimate partner. When a gun is used to murder a partner, there's 2 times the odds that the perpetrator will kill other people as well, often including children or other family members. Fortunately, there are many strategies that victim survivors use to get help, to stay safe, and to interrupt or prevent ongoing partner violence. One important strategy, which I'll focus on a bit more today, is getting a domestic violence protection order. DVPOs, these are also called restraining orders. They're the most widely used legal intervention to address IPV in the US. They're obtained through a civil process, not a criminal process. So for that reason, with the civil process, they can offer speedier and more flexible protection compared to pressing criminal charges, which can take a lot of time and money and resources. So if a request for a protection order is granted, the DVPO usually orders the abusive party to stay away from the victim survivor. DVPOs can also include other protections as well, like ordering the person who enacted violence to leave a shared residence. And when the protection order is active, the abuser is federally prohibited from owning or accessing guns. A recent Supreme Court case just decided in June of this year actually confirmed that DVPO respondents don't have the constitutional right to possess a firearm. So that was my background section. I want to delve in a little bit first about some of the preliminary research I did, or the foundational research I did, I should say, looking at the role of intimate partner violence in gun deaths in the US. This graph shows data from the CDC on gun violence overall. The x-axis at the bottom is time in years from 2010 to 2021. And then on the y-axis on the left, we have age-adjusted rate per 100,000 people. So what does that mean? In other words, if we followed 100,000 people over the course of each year, this is the number of folks who would have died by suicide in teal and by homicide in pink, with some lesser common gun deaths all the way at the bottom. So one important thing to note from this big picture, mass shootings count as homicide deaths, but mass shootings are actually not that common. Mass shooting deaths are about less than 5% of homicides. So they're important for us to be thinking about, but they are just one piece of the larger picture of gun violence. Otherwise, suicide deaths with a firearm are actually the most common type of gun death in the US. So for this project, my research question was, what is the role of IPV in intentional gun deaths? So honing in on homicides and suicides. For this project, I used data from the National Violent Death Reporting System, which is the best, most detailed data that we have on fatal violence. It's funded and maintained by the CDC. And when I began work for this particular project, it covered 43 US states, as well as DC and Puerto Rico. So it's not completely nationally representative yet, but NVDRS has been scaling up and it will be representative very soon. So how does it work? After a homicide or suicide occurs, states will obtain a copy of the death certificate, the law enforcement reports from the death investigation, and the coroner or the medical examiner reports. And so with all of these existing documents, staff at the state level will read through them and enter key pieces of information into NVDRS, usually with like a checkbox style way of reporting. They'll also compile a written summary about what they've read in these documents, just describing the situation that led up to the fatality and any facts known from the case. Unfortunately, information about IPV is not consistently recorded in NVDRS. There are some good checkbox style variables that capture some IPV information, but they don't capture everything. Often IPV might be described in the text summaries, but it's not recorded elsewhere. So to understand the role of IPV in gun deaths, I examined existing NVDRS variables, and I started reading some of those text summaries. Particularly for suicides, IPV was often mentioned in the text, but wasn't recorded anywhere else. So to address that problem, I created an automated computer algorithm to extract information about partner violence from the NVDRS text using natural language processing. This NLP approach has really enabled us to examine the role of IPV in fatal violence for the first time at a national scale. And this tool is now publicly available and has really helped grow more research in this area. So using these methods, we found that intimate partner violence was described as a contributing factor for 11% of intentional firearm fatalities in the US. So that means for every 1 in 9 homicide or suicide gun deaths, 1 in 9 are connected to IPV. And this is a pretty conservative estimate. We were really limited by what kinds of information happened to get captured during the death investigation and then wound up in NVDRS. IPV probably leads to more gun deaths, but this is just what we can tell from the data we have in front of us. So most of these cases are not getting counted in routine reporting. Routinely, we're seeing CDC usually looks at the checkbox style variables and doesn't necessarily look at the text. So we're able to build a much more comprehensive perspective on the role of IPV in gun deaths when we use this NLP approach. IPV-related gun deaths, included both homicides and suicides. And I think that just emphasizes that we need to be thinking about IPV in both of those contexts, interrupting this violence before it can escalate both to fatal interpersonal harm or fatal self-harm. So now I want to segue into discussing my current project, which builds on that work to focus on preventing one particular form of IPV-related fatality, which is intimate partner murder-suicide. Intimate partner murder-suicide is when a person kills their current or former intimate partner and then dies by suicide within 24 hours after the murder. Murder-suicide is quite rare overall, but these are distinctly common in the IPV context. Usually when someone commits a murder, they don't want to get caught or killed. But when someone murders their partner, that perpetrator dies by suicide at 20 times the rate as we would see in other murders that happen outside of an intimate relationship. So what's going on here? Here, the perpetrator might have a distorted perception where they see their intimate partner or that relationship itself as a real extension of their life and their value. And when that relationship is threatened, that can trigger a murder-suicide. Some of the common motivations or contexts that we see intimate partner murder-suicide happen can include a feeling of revenge, a desire to control or punish a partner, possessive jealousy, or even what's called extended suicide. And by that, I mean someone first has the intention to die by suicide, and they want to take their partner with them, so to say. So intimate partner murder-suicide is almost always committed by men, and there's usually a pattern of intimate partner violence leading up to the murder-suicide event. In other words, this doesn't just happen out of the blue. There are threats, controlling behaviors, and other kinds of serious IPV beforehand, which does suggest that there should be warning signs that can help us identify where there's the highest risk and then intervene to prevent these horrible events. But prevention is not straightforward. Many IPV perpetrators are suicidal. Most, however, do not go on to murder their partner. We know from a CDC survey that 26.7 million female victims of partner violence in the US who are alive and responding to the survey report that their male abuser has ever threatened suicide. So the question is really, how do we learn to tell the difference? Who do we understand is at the greatest risk for murder-suicide, and what can we do to stop it from happening? So this was really my main motivating research question here. There's been no really rigorous research published to date on this topic. And by rigorous, I mean research that compares murder-suicides to IPV situations where the partner survived and was not murdered. We see a lot of research using like a case approach, just looking at murder-suicides or comparing murder-suicides to other kinds of murders, but those don't help us save lives because of how they're designed. They can be helpful from like they have their place and they're really important. But for prevention, we really need this kind of comparison group approach. So we might assume we can use similar IPV prevention kind of ways of thinking to avoid these tragic events. But the evidence base for stopping intimate partner homicide in general is still quite limited. There's only really been one study in the US that's used a rigorous research design to identify warning signs for murder in the IPV context overall. And that study used data that was collected over 25 years ago at this point. So we really do need updated and more targeted work in this area. So building on the work I shared earlier, I used the National Violent Death Reporting System for this project, and I took a case control approach. For this setup, my outcome was men who killed their partner in a murder-suicide. And then the control group here is men who had a history of abusing their partner, but then who died by suicide without killing their partner. So in that way, we have a living comparison, which is really what allows the study design to be rigorous. Although I will note importantly here, the male perpetrator did die by suicide in both of these scenarios, but the important difference being that in the control group, the intimate partner or the IPV victim did survive. It was fairly easy to identify cases. There's good documentation in NVDRS to do that. These controls were much harder, and my NLP tool that I discussed earlier really allowed us to jump in and find reasonable controls for the study. We matched the cases to controls based on age and race ethnicity. For all cases and controls, we reviewed the text summaries in NVDRS to make additional notes about possibly relevant risk factors that weren't already recorded elsewhere. For the study, we focused only on males under the age of 70 who had a history of perpetrating IPV, because murder-suicide can manifest quite differently in older adult populations. And for the analysis, we used generalized estimating equations. For both cases and controls, a male IPV perpetrator did die by suicide. So our results really can only speak to how to save that partner's life, the IPV victim. We did this study with limited data using existing data, but I think it really builds a platform for more work in this area and more research in particular too to how to intervene to address ongoing perpetrator suicidality. Our data may also be subject to information bias. Death investigations, are conducted differently for murder-suicide events compared to an isolated suicide. So differences in data documentation may have driven some of our observed results. We did take some efforts to mitigate this risk, including controlling for the level of detail provided in the NVDRS text summaries. The study focused on the characteristics of the perpetrator. We had limited information on victim survivors, but I think it's important really to focus on the people who perpetrate harm because we can't stop IPV or gun violence without stopping the perpetration of that violence. And finally, our firearm measure looked at whether guns were used as the suicide method. We couldn't consistently measure the type of firearm use or access leading up to the fatal event. So that's an important limitation. Cindy, I want to check in. If we're out of time, I can stop it here. Oh, I think you're still on mute. Sorry.
So engaged with what you're talking about here that I forgot to take off my button there. We do have a couple of questions. Let's see. Great. Let's maybe look at these questions. So that, and then we'll see where you go. I think I may have it. You have a couple minutes. So Janice Camp asks, were there any differences between urban and rural couples?
Great question. It's something I have on my list to be looking at. I'm trying to remember. Yeah, I think that's something that I'm curious to look at. We sample from folks all around the US because murder suicide is relatively rare. We only looked at 2 years of data. But yeah, I think that's absolutely something that we need to look at next.
Fantastic. And another question from Kay. Do we know what comes first, the impulse for suicide or the impulse for partner homicide?
That is a burning question that people are hotly debating in the field, and it is quite controversial. People have very strong feelings on the scholarly side of this. But yeah, on one side, we have people really strongly arguing that murder suicide stems from the decision first to die by suicide, in which case, in some ways, it argues that the framework for my study looking at, among folks who died by suicide who murdered their partner is really the appropriate framework. So you hear that more from people on like the psych side of things, people who are in the intimate partner violence, like services supporting victim survivors. A lot of what we see from them is that these are largely homicidal acts and that suicide is almost more of an afterthought or an inevitability. But I think probably there's some truth to both perspectives and that it ranges based on this scenario. But I think there's a lot of room for more work in the area. And in fact, I'm hoping to kind of build from this project to do a subsequent study that'll look more closely at that.
Oh, that's fantastic, because I think those will be the types of information that communities will find very helpful. Another question, and I had one on it kind of add to this, is are there areas of the country that have stronger restraining orders, and those areas do those areas have higher or lower murder suicide rates?
Great question. So there's pretty compelling data at the state level that says that states with better DVPO laws, particularly that allow the courts to order the person who's enacted IPV, to order them to relinquish their firearms right when the protection order goes into effect. Those states have 10% lower partner homicide rates overall. And so it is pretty compelling evidence that this intersection between protection orders and firearm access is a really ripe area to be preventing these kinds of deaths. Now, a lot of that research is just looking at intimate partner murders overall, not necessarily honing in on the subset that are also murder suicides. But I think there's really strong reason to believe that protective effect would exist there, but I don't think it's been studied specifically.
So with that protective effect known, do you understand, or do we understand why some women may resist using or asking for a protective order?
Yeah, absolutely. I think like the legal process overall is really quite intimidating. Some people just want the abuse to stop. They don't necessarily want to get their partner in trouble. And so there's, I think, like a fear of involving the legal system. There's a fear of also causing violence to escalate. So a protection order works in many scenarios, but it won't work in all scenarios. It's in some ways it's a legal piece of paper that says, you have been found guilty of intimate partner violence. You cannot approach this person. You have to stay away from their home, from their school, etc. But it's a legal document. Like if this abusive individual is truly hell-bent on harming their partner, there's not a lot that the protection order can do in those very extreme situations. So there are a lot of people who fear that by trying to get a protection order, they're just really going to make the violence worse. So I think those decisions really have to be looked at on a case-by-case basis. Victim survivors themselves really know best their scenario and the risks they're facing and what they need to do to stay safe. So I think as allies, as friends, as service providers, and as researchers, I think our job is to help give people all the information they need to make an informed decision, but that decision ultimately is theirs.
Great. Well, there's about a minute left. Do you want to summarize what your next steps are?
Sure, I'd be happy to.
Thank you.
Let me get those slides pulled up again. Just a second. Okay. Oops. Okay, so in this minute, I'll just highlight some of my own next steps. I'm going to work on linking data from the National Violent Death Reporting System to statewide protection order data in Washington to understand how well the NVDRS is actually recording case history, protection order case history, and understanding utilization patterns of DVPOs leading up to homicide or suicide for victim survivors and people who perpetrate IPV. I'm also trying to use that data to understand, to estimate the actual suicide and homicide rates among IP victims and IPV perpetrators respectively, which is a really hard task to do, hasn't been done much in research before. So I'm really hopeful that if we can get these administrative data sets to kind of talk to each other, we'll be able to look at that in a critical sense. I'm also collaborating with colleagues on a CDC-funded project led by Dr. Alice Ellison at UW, studying how removing guns from IPV perpetrators as part of that DVPO process can decrease violence risks. So I can end it there if that's helpful.
And fantastic. Thank you very much for this informative, illuminating presentation, for the guidance that you give, and I think helping us all understand what are the next steps that we have to move in that area. So your research, Dr. Kafka's research, is an example of the type of research that the U.S. Surgeon General Advisory of 2024 states is necessary to expand our understanding and prevention of firearm violence. There's a link to this publication called Firearm Violence, a Public Health Crisis on the Foundation's website in the area called In the News. And that'll probably be helpful for you to look at after you listen to Julie Schleimer's presentation, because she's going to be talking to us about the role of advisories and what we can learn from this advisory that comes from our U.S. Surgeon General and its importance in Washington as well as across the country. So Julia is a PhD candidate in the Department of Epistemology at UW and is an important team member with the Firearm Injury and Policy Research Program. And as with Dr. Kafka's presentation, we'll use the Q&A. And as she completes her presentation, we'll go to the questions. You're on. Thanks, Julie.
Thank you so much. Wonderful. I will go ahead and share my screen. Let's see. Okay, do you all see the right thing? Good, okay, wonderful. Great, so I am very excited to be here today and talk a little bit about the Surgeon General's recent advisory on firearm violence and what it means for the field. So first, I will give an overview of the Surgeon General's advisory and examples of how prior advisories and reports have helped shape responses to public health problems in the US. Then I will briefly summarize the burden, consequences, and risk factors at a high level for firearm violence, and then summarize some of the history of firearm violence research and funding, and end with an overview of the strategies the Surgeon General has highlighted as important components of a public health approach to firearm violence prevention, including how this work aligns with what we're doing in Washington. Great, so just for a little bit of context, there are several types of Surgeon General's publications, including reports, calls to action, and advisories. And they vary in content and implications, but all really intend to draw attention to an issue and recommend change. So prior Surgeon General reports and proceedings have helped shape our national response to major public health problems over the last 60 years. For example, on the left here, the Surgeon General's report in 1964 identified the health consequences of smoking, and afterwards, Congress took several steps, including requiring cigarette packages to have warnings and banned cigarette advertisements. In 1986, the Surgeon General issued a report on HIV and AIDS, which changed our understanding of the disease and helped identify prevention strategies. And in 1989, the Surgeon General had a workshop on drunk driving, which called for strategies such as blood alcohol limits and taxes on alcohol that have been important components of our national strategy to address drunk driving and motor vehicle-related deaths. And of course, the topic of conversation today is the Surgeon General's recent advisory on firearm violence, which is really a landmark publication. But it's also important to note that while these reports and publications have had sort of great success in shaping our public health response to these issues, and they have declined substantially, they are kind of embedded in cultural, political, and economic contexts, and they're not necessarily a cure-all. So it's important that change be collaborative and involve advocacy, norm change, and other things along with science. So a little bit about the burden of firearm violence in the US. So in 2020, firearms surpassed motor vehicles as the leading cause of death for children and adolescents in the US, reflecting both the progress made in reducing motor vehicle-related deaths and the lack of progress in preventing firearm-related deaths among this age group. And as Julie mentioned, nationally, most firearm-related deaths are from suicide. And from 2012 through 2022, firearm suicide rates, as we can see here, were highest among older folks, but they increased the most among young people. And especially concerning is a rise in firearm suicide among Black youth who have historically had lower suicide rates than other racialized groups. And in fact, preliminary CDC data for 2022 show that firearm suicide rates among Black adolescents surpassed the rate among white adolescents for the first time on record. And many people experience non-fatal and non-injurious firearm-related harm in the US as well. So for example, an estimated 54% of US adults report that either they or a family member have experienced a firearm-related incident, including 21% who have been threatened with a firearm and 19% who have had a family member killed by a firearm. And these harms really cascade across society, impacting individuals, families, communities, and society as a whole. So of course, as I mentioned, including the loss of life, non-fatal injuries, those who directly witness firearm violence, those who lose their loved ones, those who live in affected communities or who are indirectly exposed, and then the collective trauma and fear that this engenders. So now I will shift to very briefly covering some contributing factors. Of course, firearm violence is a very complex issue with a number of contributing causes, but I'm going to sort of summarize a couple of things highlighted in the Surgeon General's advisory. So specifically, the Surgeon General's advisory calls out these two broad categories of risk factors for firearm violence. The first are structural factors, which significantly increase the risk of experiencing firearm violence, and they include poverty, living in an area with low social mobility, or being in a historically marginalized group impacted by structural racism. So for example, research suggests that social capital, income inequality, and social service spending are associated with firearm homicide rates, and that approximately more than half of firearm-related deaths and 2/3 of firearm-related homicides are associated with living in an area with high concentrated poverty. And it's important to note here that these factors did not arise by accident. They're often intentional and the result of deeply rooted norms and values and discriminatory government policies and practices. And the second big kind of bucket highlighted in the Surgeon General's advisory is access to firearms, which is a really significant contributing factor for firearm-related harm. For example, research shows that the presence of a firearm in the home is associated with higher risk of being a victim of homicide and suicide among all household members. And furthermore, that an unlocked firearm in the home is specifically associated with higher risk of suicide and unintentional injury among children and adolescents. And the higher risk of death attributed to firearms is in large part because of their lethality. So for example, nearly 90% of suicide attempts with a firearm end in death, which is a proportion or a case fatality rate far higher than other methods of suicide. And because firearms are so lethal, putting time and space between firearms and individuals at heightened risk for violence can often mean the difference between life and death. So now I will provide a little bit of context for firearm violence research and funding in the past. So in 1992 and 1993, two seminal papers were published in the New England Journal of Medicine, documenting this increased risk of suicide and homicide in the home in relation to gun ownership. And in response to these papers and to lobbying from the NRA, Jay Dickey, a Republican representative from Arkansas, authored this rider in the 1996 omnibus spending bill that mandated that, quote, none of the funds made available for injury prevention and control at the Centers for Disease Control and Prevention be used to advocate or promote gun control. And this had a really chilling effect on gun violence funding and research. As shown here, gun violence funding on the left and gun violence research on the right are significantly lower than would be expected given the mortality rate attributed to firearms. But happily, over 20 years later, in 2018, Congress updated the language of the Dickey Amendment in this omnibus spending bill to clarify that while appropriations language prohibits the CDC and other agencies from using funding to advocate or promote gun control, the CDC has the authority to conduct research on the causes of gun violence. And finally, from 2020 through 2022, the CDC and NIH awarded approximately $49 million and $100 million, respectively, for firearm injury prevention research. As shown in these figures. And so as a result of these appropriations, the take home here is that federal funding in firearm research prevention volume increased substantially. So now looking forward to the Surgeon General's recommendations for a public health approach to firearm violence prevention. The Surgeon General Advisory notes that a public health approach is designed to prevent and reduce harm by changing the conditions and circumstances that contribute to risk of firearm violence as measured by deaths, injuries, as well as the reverberating mental health and emotional impacts detailed in this advisory. And it's also very much about collaboration and cross-sector efforts, as highlighted in this other quote on the screen. And the Surgeon General's advisory specifically highlighted several categories of investment and specific strategies within each of those categories, which I'll summarize now. So the first category is critical research investments, including improving data sources and data collection to inform prevention activities. So this includes things like bolstering national data collection systems for non-fatal injuries. Second includes expanding research to examine short and long-term outcomes of firearm violence and evaluate specific prevention strategies. So very much like the work that Julie presented. Third is conducting implementation science research to improve effectiveness of prevention strategies. And implementation science is important for supporting the adoption and sustainability of evidence-based strategies and to help ensure that these strategies don't have unintended consequences. The second broad category is community risk reduction and education prevention strategies. And one of the key aspects under this category is implementing community violence interventions to support populations with increased risk of firearm violence involvement. And these community violence interventions employ credible messengers to disrupt cycles of violence and connect those at heightened risk of violence with services that address and improve their needs and circumstances. Additionally, this category of prevention strategies includes incorporating organizational violence prevention and emergency preparedness into safety programs. It includes encouraging health systems to have and facilitate discussions on safe and secure firearm storage, especially for populations at heightened risk, including children, those with cognitive impairments, and behavioral health problems. And lastly, this includes addressing structural determinants that increase the risk of firearm violence, including in domains like housing, education, economic opportunity, and the built environment. The third category here is firearm risk reduction prevention strategies, including requiring safe and secure firearm storage, such as through child access prevention laws, implementing universal background checks and expanding purchaser licensing laws, implementing effective firearm removal policies, including for those such as extreme risk protection orders and domestic violence protection orders, banning assault weapons and large capacity magazines for civilian use, creating safer conditions in public places related to firearm use and carry, including more restrictive concealed carry laws and laws governing the use of firearms in public, such as stand your ground laws. And finally, treating firearms like other consumer products, including safety regulations, warnings, and smart guns. The last big category highlighted in the advisory is mental health access and support, including increasing access to affordable, high-quality mental health care, substance use treatment, and other trauma-informed resources, particularly for highly impacted communities, both as a prevention mechanism and in the aftermath of violence. And then lastly, enhancing safety measures and mental health resources in learning settings for children and adolescents, such as bolstering the school-based mental health workforce. So now I'm going to very briefly highlight some of the work that we're doing at FIPRIP, the Firearm Injury and Policy Research Program at the University of Washington. And you can find all of our current and recent research projects on our website, which is listed at the bottom and then also on the last slide. So one project led by Dr. Ali Rohani Rabar, our programs director, focused on improving ICD-coded hospital data systems in measuring non-fatal firearm injuries by intent. So this really aligns with the category of improving data infrastructure. Another project led by Cami Rankin and funded by the Grandmothers Against Gun Violence is focused on the aftermath of mental health, is focused on the mental health impacts of school shootings. Another project on which I work, along with the other lovely people shown here, is social impact evaluation and assessment of community-based youth firearm violence intervention and prevention programs across the state of Washington. My dissertation specifically focuses on the early childhood education policy and its potential impacts on violence and firearm-related behaviors across the life course and intergenerationally. Another project led by Dr. Christian Jones focuses on how community-based youth mentoring programs can prevent firearm violence and promote social justice. And then the last project I'll highlight, of course, there are many that I couldn't highlight, is one led by Drs. Kelsey Conrick and Ali Rohani Rabar with support from Maria Carter Quadro, and focuses on evaluating statewide programs that distribute firearm locking mechanisms into community settings. So now I'll shift to really briefly talking about some of the policies we have in Washington, mindful of the time here, and I want to leave time for discussion. So in Washington, we have background checks for private sales, which fill a gap in federal policy, which just requires background checks for sales made by licensed, federally licensed firearm dealers, but not private sales. In terms of concealed carry laws, we currently have shall issue policy, which means that our police must issue a concealed carry license to anyone meeting criteria, which is less restrictive than may issue policies in which police have discretion. Regarding child access prevention policies, Washington has a negligent storage law, which allows prosecution of adults who allow children unsupervised access to firearms. And then we also in Washington have institutional dedication to firearm violence prevention, including with the State Office of Firearm Safety and Violence Prevention, the Regional Office of Gun Violence Prevention in King County, And as I mentioned earlier, the Firearm Injury and Policy Research Program, whose mission is to inform, develop, and evaluate equitable programs, practices, and policies to prevent firearm-related harm, including via dissemination and information sharing. And so I've just highlighted there, we have a whole page on tools and dissemination on our website. I have just one more slide, but I think I will pause here and I can pull that back up if it's of interest. These are just some areas that I'm particularly interested in as in terms of future research investment. Oh, I think you're muted.
Thank you for that reminder. Washington passed a safe storage law a few years ago. Do we have any evidence of the impact of this law? Is it keeping children in gun-owning homes safer?
This is a great question. Actually, I was recently involved in a conversation about this. It hasn't been, to my knowledge, evaluated, but we have other evidence from other states showing that child access prevention laws are important ways to reduce firearm-related injury and death among young people. And so I think it's really important that we evaluate that law in Washington. And we have some additional data that can contextualize that coming from survey data, asking about storage practices in the home and how that's changed over time.
So do you see any barriers or any roadways forward for that study maybe to occur?
So we're working on one study right now to analyze trends in storage. And then in terms of a study kind of evaluating the impact or effectiveness of the child access prevention law in Washington, I think research funding, personnel, folks to work on that study is always important. And better data, as I mentioned earlier, we really only have kind of reliable, valid data on fatalities, but we're missing a huge chunk of what's happening in terms of non-fatal injuries.
Maybe something we need to talk to some legislators about, huh? Yeah. So what are some of the biggest challenges in conducting research in communities impacted most by gun violence?
That's a great question as well. I think a couple of things. One is a historical kind of earned mistrust of research, because research has historically either not been very helpful and even inflicted harm on community. And so I think there's a lot of recognition that we as researchers need to do on that, and reflection and work to earn back trust and authentically collaborate with communities, because really the folks who are closest to the issues and living and working in communities that are most impacted have so much knowledge, expertise, and wisdom about the context of what's happening and ideas for solutions. And so as I briefly alluded to, we've been doing a lot of work at FIPRIP to try to build those relationships and build those collaborations, and it takes time. And it also takes capacity building on behalf of everyone involved, including community organizations who are working in this space, but don't necessarily have the investment to create these robust data collection systems, for example.
That's such, excuse me, such an important point, as we understand that working communities is going to be essential to reducing gun violence. Another question: which states have evaluated their safe storage programs?
I'm not actually aware, or I don't recall off the top of my head the specific states. I can certainly find that information and pass it along. And I'll also plug here, the RAND Corporation has a phenomenal kind of gun policy research program where they not only study firearm laws, but also kind of synthesize the evidence. And so they have summaries of the sort of effects of these laws, and then they provide a lot of detail as well in a state law database of which states have which laws, when they were enacted, and the kinds of provisions. So that's a really helpful resource as well.
That's a very helpful resource for those of us who are doing the advocacy work now to help our legislators in Washington understand where we compare to others, as well as why we are leaders, I do believe, in the area of gun violence. Do we have time for, oh, here's another question. I can get to it. Oh, there we go. Another more question. Cheryl here. Is any researcher here in Washington investigating ammunition access, background checks to buy and store ammunition?
Great question. And I am not aware of anybody who is. Maybe Julie does, but I think this is also a really important area that should be looked into.
So maybe we have someone listening here. They could reach out for that area and find that out. Because I think that again is another area that's so important, especially as we're talking about ghost guns and other types of things that are impacting our field today. So we have a minute or so for you to finish your presentation.
Wonderful. Okay, so like I mentioned, I just have some thoughts on kind of personally what I think are particularly important areas for further research investment in Washington. And this is not necessarily a comprehensive list, and many of these really do echo and uplift the points made in the Surgeon General's advisory, and which I mentioned earlier. But first, as noted both in Julie's talk and in some of the questions that just came in, it's really critical to continue investing in data infrastructure, including surveillance and integration. Currently in Washington, we have many different data sources that collect valuable information across community settings, health systems, criminal legal systems, and social service settings, but we need continued efforts to integrate them. And then also, again, as just came up in some of the questions, there's a need to further study firearm policy and program implementation and effects, such as those that attempt to, policies that attempt to put time and distance between people and firearms, and how those policies get implemented on the ground. There's been some fantastic work by colleagues, including Dr. Alice Ellison, on implementation of DPPO policies in King County, along with the wonderful work, of course, that Julie has done. And then I'll also highlight a particularly exciting area, I think, is studying policies that shape social determinants of health. Because these are so tightly linked with firearm violence risk, they really have the potential to meaningfully shape the population distribution and risk and inequity that we see in firearm violence. As I just highlighted, also another important area is studying the implementation and effects of community-based violence intervention programs, which are really increasing in prominence, promise, and they're increasingly recognized as strategies not only to prevent violence, but promote community healing and well-being. And there's amazing work being done in Washington as well as nationally. And so it's important that we continue to understand how those programs work and what they need to be successful, including investments in data infrastructure, among other things. And then relatedly, it's really critical to deepen partnerships, including interdisciplinary research teams and community-based participatory research approaches, which really center the expertise of those with lived experience. And as I referenced, this is an area that we've been working hard at FIPRIP, and it really does require continued effort and investment. So that's it. Thank you all so much. Feel free to check out our website for the Firearm Policy and Research Program, and feel free to email me as well with any questions or comments. Thank you again.
Well, Thank you, Julie and Julia. This has been an amazing hour, gone very quickly, and I got lots of questions and ideas, but I am sure we have inspired many of the grandmothers and those others who are watching today to think about the importance of the way that we spend our dollars and that we spend our time in supporting. I want to remind us all that we do occasional more programs like this. They're sponsored by the foundation to share research and to share ideas, because we feel it's important that as we advocate and as we speak with others, that we have background in research to support our statements. So if you think about if joining us today in donation to the foundation, it would be highly appreciated, because it's our donations that allow us to support researchers like Julie and Julia in continuing to help us understand how we can work together to decrease gun violence in our communities, increase healing, and build communities that are safer for all of us. So again, thank you for joining us today, and we hope to see you next time. Ladies, thank you.